MD Conference Live presents updates from the European Society of Cardiology in Barcelona.
We're quite interested in the study you just reported on, and I hope that you will be able to summarize your key data for us.
So this is data coming from the GRACE registry, which is the world's largest database on acute coronary syndromes. And we have looked specifically at very sick patients, those presenting with unprotected left main coronary disease. And as you know, we have no randomized study to tell us what we should do in terms of management, revascularization of these patients. And we have altogether almost 1,800 patients, and we have three groups: those going to the OR, those going to the cath lab for PCI, and those medically treated. And actually what we see is that revascularization is associated with better outcomes than medical treatment at 6 months, but altogether we have a very sick population with high death rates, 7.7% in hospital, 14% at 6 months. Of course, we have in this population acute patients, ongoing ST elevation MI, for example. We have shock patients. We have even some patients hospitalized after a cardiac arrest. So that explains these death rates. But this is a very sick population, never studied in a randomized study.
And what were the significant trends that you discovered in your study?
What we saw is that along the 8 years of this study, there was no change at all in the level of risk of these patients. They are the same now than they were before 8 years ago. But our practice has changed, and we do more and more PCIs and less CABG, especially for these emergent cases. Ongoing ST elevation MI, shock patients, they go to the cath lab for a coronary angioplasty. They do not go to the OR for CABG. While, as you know, the recommendations that we have say that left main disease is a very good indication for surgery. But in an emergent situation, a place where we have no randomized study, what the physicians do these days is to use percutaneous coronary intervention more than CABG.
I see. And were there any surprises in the data that you were studying?
One of the surprises, I guess, would be the level of strokes that was associated with CABG. A big difference with the other two groups, medical management or PCI, we had more acute stroke, ischemic stroke especially, but not only ischemic actually, and in the group of patients going to the OR. And this has been reported recently in a study, the SYNTAX study, looking at stable patients. And what we found is exactly the same thing. Stroke is a frequent complication in patients going to the OR for CABG surgery. So this is a devastating complication, of course. We don't like this type of complication. Little that we can do when it occurs, and clearly it was a surprise a little bit to us.
Mm-hmm. In general, as you review your study, what is the takeaway message for physicians?
The first thing to do is probably to evaluate these patients very carefully when they are admitted. And if it is an emergent case, an ongoing ST elevation MI or a shock patient, the physicians have to know that there is no recommendation, no randomized study to guide them. And what they do these days is probably a good thing. It's to send a patient to the cath lab and perform a PCI if it's possible when they have a left main coronary stenosis. If it's not possible, they have to do something else, maybe to treat these patients medically if the patient cannot go to the OR. And what we have seen is that 40% of these patients medically treated initially because they had some form of contraindication or because technically it was not possible to do a PCI, 40% of these patients later on, during the 6 months period of follow-up, went to the OR for a scheduled surgery. So if they can survive the acute phase, some of them could be re-evaluated for surgery and do well on surgery a little later.